This clip is sponsored by American Mobile. If you're a nurse interested in traveling, visit AmericanMobile.com to get started. Let's talk about more specific stick use stuff. So, what is your patient population really in surgical trauma? Like, what are the main people that you see?
Sure, yeah. So we are primarily adults. So we do 18 to 101. Um, we
And the cutoff. That's the
that's
cutoff.
it. Well, I think that's the oldest trauma patient I have seen
Oh,
is
wow.
101.
Okay.
And and trauma is one of the leading causes of injury in adults. Um, and so
Mm-hmm.
we see anywhere from, I mean, you have your low level motor vehicle accidents. They maybe have a small head bleed and they want them in the ICU for frequent neuromonitoring,
Mm-hmm.
just to make sure that the bleed doesn't get worse or they
Yeah.
decompensate. Um, so we, do those Q 1 hour neuro assessments, keep them up all night, and they love us so much.
What's your name?
Yeah.
What's your
Where
name?
are you?
With the pen
Yeah,
light.
where are you? What are you doing
Where?
here?
God, it's so awful. But it's
It
necessary.
is.
People will change. But yeah, I
Yeah.
know.
It's one of the
The neuro
I have
ICU, I
seen
can't
those. Yeah,
imagine.
and I've seen those. You go in the first that hour, it's 11 o'clock. You're talking to them, and then the next thing you know, you go in there and they can't move their right side, and they've got a
Yeah.
droop, and you're like, oh man, that's a bummer.
Dang
Yep.
it.
Yeah.
That's a bummer. We gotta go to CT.
Man, I hate it when that happens.
Yeah.
So we get orthopedic traumas. So we do external fixations and frequent neurovascular checks, so pulse checks. Um,
Mm-hmm.
we do management of open abdomens. So if you have a motor vehicle accident, for example, and you sustain an abdominal injury, we do, your primary assessment is done in the ER. It's usually done in the trauma bay. And if you have any kind of abdominal injury or process, you go to the operating room. They do what's called damage control surgery. So they go in, they find either the source of bleeding, or maybe you have a hollow viscous injury. So you've got a ruptured bowel somewhere. They manage those, they stabilize them. They usually leave them open. So if you have any kind of leakage, any kind of bleeding, we usually like to keep people open so that we can do serial washouts, returns to the operating room.
Wow.
So we manage those patients. They usually come to us intubated, with breathing tubes and
Yeah.
sedated. So that's one of our large volume resuscitation patients where
Sure.
they've lost crazy volume either in the OR or in the field. And so it's a lot of blood product. That's a lot of crystalloid and colloid resuscitation.
So how do you keep them open? Do you like clamps and stuff are like still
Yeah,
there
so
or
usually they're
like
packed. They're packed with pads, or packed with
okay.
packing, and then our ICU manages with wound vacs. So
Oh, okay.
we do
Okay.
Abthera wound vac therapy. So it's a a sponge that kind of goes into their
Sure, sure.
their abdomen. We usually protect their viscera, and then we put the sponge on top, and then the
Okay.
vac therapy. Um,
Okay.
but
So it's not completely. I was like, how do you keep that sterile? I feel like everybody would go into septic
Yeah,
shock.
no, and I mean, and back in the day, here's one of those examples where every surgeon is still managing those patients differently.
Mm,
We have 4 trauma surgeons, and they manage their open abdomens differently.
yeah.
And this is where I was talking to one of those low, small SICUs that's still managing with just sterile drape. They just take like that plastic drape and just stick it on their abdomen and send them to the unit.
That
So
would
yeah,
make me so nervous.
yeah, and so that when that's really how you, depending on how they're sent out to you, depends on how you manage them. So, for example, way back in the day before I started in SICU, we used to medically paralyze all of our open abdomens so that they didn't move, so that they didn't have that opportunity to cough and dehiss, or they didn't try to sit up and crunch their abdomen and dehiss or rupture. We don't do that now. My ICU does not do that now. I have a trauma surgeon who loves to try to extubate his patients with open abdomens. But you have to think what comes with that: pain control. So we have a really hard time managing these people's pain because they have a massive open wound. And so we always advocate against extubating patients with open abdomens, only because it's very challenging to control their pain without continuous narcotic infusion.